So I think just like how Sisimosa said, is absolutely there is no high order aberrations which is necessary, because when we're looking at the corneal plane, it's a fixed factor which if you do treat everything, you should have, or you're creating a more better optical system.
Yes.
But when we look at a wavefront, then we have a more complex one. So when we're looking at topo-guided treatment, always remember, no matter if you do the full treatment, high order aberrations, you are creating a better optical system. But the question is, what would his refraction be if you're treating a lot of high order aberrations? So that is the key.
Exactly. I think we can reduce the entire discussion actually in three major points. What are the surfaces that we can measure? And what are the contributing factors that we can't measure? Okay, so we have actually in the entire process, to finish what we discussed, is wavefront did not prove necessarily better data, but proved to be a good tool to understand optics. Topography guided, our FDA result, showed that by treating the anterior corneal surface, you get better uncorrected visual acuity. And for the first time, FDA agreed that the results we achieved was better than glasses and contact lenses. This is fact. This is fact. Second fact is, we measure the anterior, we measure the posterior, not very qualitative highly, but we know what the posterior surface does. We know what the total wavefront is for one situation, whatever we measure. The questions that are not answered is, first, why is a patient having a certain visual impression? There I would go back to 300-400 years ago where we had only sphere. What did we do with patients when we did refract them? We did give them sphere, right? Some of them reached 20/20 because they had sphere and a little bit of astigmatism, but some of them, especially if they had more astigmatism, they didn't see well. So a couple of hundreds years later, we had cylinders, right? So we could help the patient also with cylinder. Now we know there's coma, we know there's spherical aberration, we know there are other higher order aberrations, but we are not able, except with Pablo Attal's machine, to put it in a phoropter. So therefore, the discrepancy, and again, I will say this maybe sometime again and again today, for patients where there are no higher order aberrations, the life is so easy, because the Zernike polynomials work well, the visual impression is very much similar to what you measure in the anterior cornea. If you start to have higher order aberrations, then you have two things that not work anymore. First, the Zernike calculations of refraction, and the patient that uses maybe a little bit astigmatism to compensate for his coma. If you want to have a patient with me that has 3/4 of diopter on oblique 125 degrees astigmatism, the cornea is a quarter with a rule to a half a diopter with a rule. Now the visual impression that the patient has is, I need help for my oblique because this is bothering the most. So he takes the astigmatism to correct partially his oblique coma. And this is something that we are not having. And so we are lacking actually for three things. We are lacking on the possibility to measure or to have the patient fully corrected with higher order aberrations to really judge what his lower orders are. If you like, a phoropter with adaptive optics. Yeah. The second one that we lack is, what are the higher order aberrations? If you calculate them back to manifest, gonna affect the patient's visual impression and manifest refraction. So those two things we did develop in 2000 wavefront, but we forgot to do this. Gatinel has an approach. I don't know if you went to his site, where he tries to make the calculation of the measured refraction a little bit, not a little bit, actually quite a bit significant, not depending anymore to higher order aberrations. And maybe one day we will have other.
So basically, to sum up what he said, is there are a lot of things which are dynamic, there are a lot of things which are static, but when the patient has something which is higher in him, so that means your machine may not be completely knocking it off like this, Most machines have software which just knocks off what is necessary and keep probably what is not. For example, if you have a smarter machine, the machine would probably not, if you just put this on, for example, these may be a good aberration for this patient, like you said. For example, you just put all of them off, nothing happens. Put all of them off, nothing happens. Put all of them, the lower order ones off, whatever. I'm making it very simplistic, it's not very as simple as it is. But the ones which is abnormal is your coma, your spherical aberration and coma. This dominates your cylinder there.
Dr. Shetty, I have here a small objection. The fifth order might be so low
that it may not be bothering yet
at
all.
It's not there at all. So if you actually the best way to know if it's important, because this thing doesn't tell you what the patient needs to see well. It just tells you what the point spread function is the best one, so that it's an infinity.
It's like a dot.
Point.
Yes.
Exactly. So if you switch something on and off, the effect is, if there's nothing, there will be no change.
No, I just wanted to show that machines do have thinking in them to think which needs to be changed and which needs to be done. Praveen, you said ask something?
I just wanted to ask, do we need to take into consideration the resting pupil size of the patient? Because some people have...
No, at this point of time, we do exactly what has been asked, because make the patient a little more relaxed. For example, I'll show you a concept of real time. How does the lens accommodate? There is a Osiris. If she's actually measuring it real time, I think Samaresh can talk about this.
I've used this machine sparingly, but it's an interesting machine because it gives you a real-time aberrometry of the patient, and it also gives you like...
This is accommodation happening real time, and just see at some point of time he's pseudo-accommodating already. This is what you said. At some point you can see a bow tie kind of coming. That's because the lens is accommodating for his lens, the corneal astigmatism there. But he is little stressed here. Here he's actually pseudo-accommodating. Usually a person who is accommodating very well will have a lot of greens to begin with. And the person, he's a myope, but when you're stressed, this is what happens. Suddenly when your person is stressed and you're doing this without making him relax, his pupil is also on the larger side, right, Samaresh? This is pseudo-accommodation, because that means the lens is already myopic. That's why it's showing red. If there are any volunteers, I can just test it. So, you want to test it? Kavita, you want to be here? Let's see what your accommodation is. It's very interesting because it's very important, because this is when the machine is actually, when you're doing your contour, the machine tells you that you have to treat 2.5 diopters, but the topography says you have to treat only 1. That's because the patient may be actually pseudo-accommodating. I
think she should be careful. This might show her age also.
Show her what?
I said she must be careful. This might show her age also.
We'll write as 16. Yes, Samaresh? Where do you use it in your practice at all?
So we had it for some
we don't need it for your practice actually, but this helps you to understand a lot of things.
So it has an optometer in it, like a Barral's optometer, so it does a refraction. And then with fogging, it sort of relaxes your accommodation, and then it starts to initiate an accommodative surge in the patient's eye and gives multiple accommodative impulses. It tracks the pupil, tracks the accommodation real time, and eventually you get a very interesting graph. You can see real time how the green, which is the patient's paralyzed accommodation, starts going to red when the patient tends to accommodate. So younger people and emmetropes...
This is a good accommodation. No,
it's just a bit, but like she's more or less relaxed at this point in time. But the moment the accommodative amplitude comes over there, the whole graph turns to turn red, which means the patient is shifting towards myopia. And depending on many factors, myopic status of the patient, age, the stimulus are different.
Why is this important is because it tells you the reason sometimes the patient's cylinders are always higher sometimes than the patient acceptance. Because, right, Yatish?
Definitely.
So, you have that picture, the graph?
So this is one of the important factor which stresses on the importance of doing a dilated examination or a cyclorefraction pre-op, because a simple, where you don't undilated and dilated, you have a disturbancy, then there is something happening or patient is accommodating. So you have to, if he's highly accommodative, he's already wearing unnecessary high power when he comes to your OPD itself, make sure you put on relaxing, either you put him on atropine or the cyclosporin to relax his muscles, then go for a repeat refraction and then go for it.
I think she has a little bit of lenticular cylinder. Let's see what happens. So now she's accommodating. You can see that accommodation comes. So that means that accommodation also changes dynamically all the time. Sometimes you have cylinder, sometimes you don't have cylinder. The whole concept of accommodation being just driven by lens moving up and down just does not exist in real time. So what happens is these factors have to be considered when you're planning your contour also. So to sum up on this particular discussion, what is important here is when things don't match, it's not the fault with the way you're taken the image, where the machine, the topolizer is sending the image, or the way the cornea is doing. That when it does not match, it means that the patient has something different inherently. That means he may have a higher lenticular cylinder, or the patient may have a higher corneal cylinders, or the patient may have a higher corneal aberrations. So that is the take-home point. And Vaitheesh, just quickly explain what this graph is, because we'll be using it in this session for a little bit so that people will understand what this is all about.
Yeah. So if you look at this graph, the red line that you see here, the red line points to the accommodative stimulus. So initially the accommodative stimulus is at 0, and the device gives a 3 diopters of accommodative stimulus. And then with the 3 diopters of accommodative stimulus, you measure what happens to the pupil and to the accommodation. So the green line that you see is the pupil diameter change. As the patient accommodates, the pupil constricts. And the blue line is what is the amount of accommodation that is happening. In a normal patient, the amount of accommodation should be just as sufficient to the accommodative stimulus. If there's a 3 diopter accommodative stimulus, most patients have a 2.5 to 3 diopters of accommodation that is induced. If you have a greater amount of accommodation that is happening, that means the patient has either an accommodative spasm or the patient has some aberrations in the cornea which is making the lens accommodate more. So this is especially useful in the other scenario when your measured cylinder is actually much lesser than the refractive cylinder. So for example, if the patient has a 3 diopter cylinder that you do measure on refraction, but the topography shows only a 1 diopter cylinder. So in these cases, what happens, the 1 diopter cylinder may not be completely astigmatism. There may be a component of it which is coma. So what happens is the lens accommodates to compensate for the coma, leading to a 2 diopters of induced cylinder. So in those cases where you have the measured cylinder which is lesser than the refractive cylinder, this kind of accommodative testing, if you don't have this device, even an accommodative convergence testing should be able to show that the patient is either having an accommodated, either an increased accommodation or an altered convergence. So these patients will require an orthoptic evaluation.
So basically this machine is nothing but just to understand what is happening inside the eye. It's not 100% a necessary equipment that all of us should have. The second major benefit of this particular machine is to actually counsel the patient what is happening to his eyes. Because so many times post-surgery, they go into an accommodative spasm and it takes a pretty long time to get them off it. So when you visually see this is what is happening in your eyes, to explain to him what is happening inside, and it is not, because the first thing what the patient wants to do is, something's gone with the treatment, you have done something wrong to my eyes. So when you show this, for us it becomes much more easier for the patient also to understand becomes easier.
Because one of the graphs we're going to show you is exactly matching to this patient, and then I will end it, because this is something which, where the third concept, where the three concepts, one, everything matches, the second one, the topography is higher than the acceptance. The third one, the patient has very high acceptance, but the topography is showing as, say, 1. So I'll just plug in on the computer and just show you one graph. Can you just plug the topolizer? And then I will end this talk so we can start with some practical plug and play of real-time case discussions. Because this, what Naren and Vaitheesh explained is very important because, topalize. This is what I just mentioned. This pattern, -1, patient has a -1 diopter of acceptance, but the cornea says is as 0.82. Why does it happen? Is because the patient is accepting more cylinder because there is more changes. So how do you know that it is coming from the lens and not from the patient's cornea? Is when you actually do your zero ablation, you can see that there's very minimal level of aberration out there, that is just -6 and 2 diopter. So that means that the entire issue is coming from your lens. And why does it come from the lens? Is exactly what we just showed here. So we had 3 concepts here when everything is matching. If you go back to one of those cases when everything matches, the 0-0 thing, when you do that modified one, is probably the most useful point in a contura. So that every time I do that, because it tells me who is the culprit. For example, to the 0. So here everything is matching. The patient has 1. Look at that 0 rule. It's perfect. So that means virtually, I'll finish this, then you can speak about this. Virtually the patient is completely a perfect case. This is 65 to 70% of your practice. So which is no brainer. You don't need to do anything. Do what you normally do. The second case is when the patient has a higher do it 0. Look at this. So what happens is the patient acceptance is, he's accepting 1 diopter from the cornea, and actually what he's saying is 2.25 is your cornea, what is acceptance. And look at, minute you make it 0, you have a huge chunk of ablation out there around close to 12 microns, which means it comes to your second group where the cornea is irregular because there is a lot of aberrations. The third group, I'll finish this, then you can speak about this, is the second group is around 20% of your practice, which is always a challenge. And the third group is the patient acceptance is higher, but the cylinder on the topalizer is lower, and it's very minimal, 4 to 5 microns. So Sisimos?
Can I have the first patient again where the difference was there? A very low astigmatism relatively, the very first.
You want the one with the patient acceptance was higher, or the topalizer was higher?
The topalizer was higher. The very first one.
That Anuba lady.
Because we've been discussing this with Dr. Gekle, and he has a very good point. And I was also a little bit, not that one. No, not this one.
Yeah,
before that. The very first case.
The first case where I think the lenticular was higher. I mean, just to hold on to
where you assumed it was lenticular, exactly. That one would be very interesting, because I see two things that we would like to add.
The lenticule was higher?
Can you bring this up?
The first one.
The lenticular case. Exactly. Didn't look quick enough. Exactly. If you go back to 0, and can you give me a 6.5 optical zone, because my brain works always in 6.5? Thank you. So we have here
6 microns and 3 microns.
3 microns. So there is also a little bit of consideration there that this they are now 1.0 to 1.6. Go down to 6. Go to 6.
This is a perfect one. This anyway we would do a contour on this patient because it's matching. Everything is
matching. So we have
matching.
17 degrees now. You see that how it's changed?
Yes, that is a degree change. Yes.
Can you? So I just wanted to show you one thing. What we could do here is, you see the axis and the power is changing. The axis stays stable, so we have 17 degrees of difference. Yeah, the power is quite similar, but why 17 degrees? I think if you look at it, you can see also that there's a certain amount of higher order aberrations here in this area, especially running through his pupil.
That's one of the reasons why we should do contour in this.